Hi everyone, I'm Delaney Fisher, a fifth year PhD student in the Price Lab at the University of Virginia, and I'm excited to be sharing our work with you today, where we've been applying focused ultrasound blood-brain barrier opening approaches to this disease known as cerebral cavernous malformation. And this has been a collaborative project between our lab, the Tversky lab, and the Miller lab, all at the University of Virginia. So I'd like to start out with some quick background on this disease known as cerebral cavernous malformation, or CCM. Cavernous malformations are hemorrhagic vascular lesions that occur in the central nervous system. And if we look at this diagram on the left, we can see that these are happening at the capillary level where we have dilated vessels filled with slow-moving blood and are leaky. This disease is diagnosed and monitored with magnetic resonance imaging, or MRI, and affects about 1 in every 200 people. This disease can be inherited or sporadically acquired through the biallelic loss of function of one of 3 CCM-related genes, including CRIT1, CCM2, or PDCD10. And for most patients, they don't realize that they have this disease until they begin experiencing neurological symptoms, which can include persistent headaches, blurred visions, or even more seriously, seizures and stroke. And these symptoms typically arise from a cavernoma that has begun to hemorrhage. And after cavernoma initially hemorrhages, it's at an increased risk for rehemorrhaging in the next few years. The current standard of care for this disease is surgical resection of the cavernoma. However, this presents high risk to the patient, and some lesions actually are not operable due to their location and vital brain tissue, which really motivates the need for non-invasive modalities like focused ultrasound, which can target specific cavernomas and even reach these deep-seated lesions in the brain that aren't options for surgery. In particular, we have been interested in developing focused ultrasound blood-brain barrier opening techniques for the treatment of CCM. And this approach can be helpful for increasing the local dose of already promising pharmacological candidates, but it can also help us to unlock delivery of larger molecular weight biologics like antibodies and gene therapies, which currently are not feasible due to the physical barriers that against their transport. However, before we can begin exploring focused ultrasound, we first need a model of CCM that accurately represents the human pathology. So we, in collaboration with the Tversky lab at UVA, have generated chronic mirroring models of CCM using a Cre-inducible knockout of CRIT1, one of these CCM-related genes. And we find that these models do indeed represent the human pathology of the disease. So if we look at these bright field images of our model, we can see that CCMs are forming throughout the brain. And we also see in MRI that these lesions appear hypointense and align with confocal staining of these lesions with isolectin staining shown here in green. We then went on to optimize protocols of multiple clinically relevant MRI sequences to enable the longitudinal characterization of the baseline lesion progression in our model. And we specifically used T2 space imaging for measuring the lesion volume. We used susceptibility weighted imaging, or SWI, to assess hemosiderin, which is a blood breakdown byproduct which accumulates in these cavernomas. And then we used T1 contrast mapping to assess the permeability or leakiness of these cavernomas, where we can see highly leaky lesions appearing with red here or warmer colors with this color map. And we find that in our model, the lesion volume and lesion permeability both increase with age in our model. And when we think about therapeutic intervention, we see that the optimal treatment timing is likely between 2 and 3 months of age, which is prior to this drastic increase in lesion burden that we see in our models between 3 and 4 months of age. So going into our focused ultrasound studies, we had several questions about our blood-brain barrier opening approach, as focused ultrasound has not yet been leveraged for CCM treatment. So first, we wondered, what are these safe and effective focused ultrasound parameters for this protocol? And we'll specifically explore peak negative pressure later in this talk. We also wondered if we would be able to open the lesion core, which, as a reminder, is comprised of dilated vessels filled with slow-moving blood. Or rather, would we be opening the blood-brain barrier of the vasculature that surrounds the lesion, which we call the perilesional microvasculature? And in designing our initial experiments, we selected cavernomas to be targeted for sonication from our MRI images. We then used an intravenous injection of microbubbles along with our standard blood-brain barrier opening protocol and explored 3 different peak negative pressures of 0.2, 0.3, or 0.4 megapascal. And to walk you through the results of these experiments, we have on the top row of this left figure our high resolution MRI images where we selected lesions for targeting with sonication, and we have those denoted here with these different colored arrows. In our middle row, we have our pre-sonication images, which are 2N weighted and taken after gadolinium contrast agent injection. And then in our last row, we have our post-sonication images where you can see the degree of blood-brain barrier as an increase in contrast and enhancement. So from left to right, we treated with 0.2, 0.3, or 0.4 megapascal, and we find that unsurprisingly, the blood-brain barrier opening increases as a function of peak negative pressure, which we also have quantified here on the right as the full T1 contrast enhancement over the pre-sonication images. We also wanted to ensure that these treatments did not exacerbate the targeted lesions, so we followed up with our T2 space and susceptibility weighted imaging sequences following treatment. And we've shown in a separate study that these sequences are able to detect adverse events when LPS is injected into our model, which we know exacerbates the lesions. So we see here that both T2 space and susceptibility weighted imaging can detect these increases in the lesion burden or lesion hypointense margins, indicating that we can detect adverse events with these sequences. So going back to these mice that we treated with focus ultrasound, we followed up with susceptibility weighted imaging 24 hours after focus ultrasound, and we see that we do not have any increases in the hypointense lesion margins 24 hours after treatment for any of the pressures that we utilized, indicating that our treatment did not induce an acute hemorrhage. And if we look at the pattern of contrast enhancement, which is surrounding the lesions and not within the lesion core, we see that this is indicating that we are indeed opening the perilesional microvasculature rather than the lesion core itself. And this is an interesting finding, as when we look at confocal imaging with CD31 staining for endothelial cells in our model, here this dark hole is our CCM core. We find that in the perilesional microvasculature space that this vasculature is actually enlarged compared to what we would expect in normal healthy brain tissue. So it was surprising to us that we actually did indeed still have the same degree of blood-brain barrier opening as we would expect in wild-type mice with healthy vasculature in our model with an enlarged vessel phenotype in this space. And going back to our motivation for pursuing focus ultrasound blood-brain barrier opening in our model, we wanted to explore antibody delivery, and I want to focus on this specifically for the rest of the talk. So typically in our lab, we've used a repeat barrier opening regimen for antibody delivery so that we can increase the dose of antibody delivered to our mice. And we stage this repeat barrier opening 3 days apart, which is around the half-life of antibodies in mice. But we wanted to ensure that this repeat exposure would be safe in our model, given the altered vasculature that exists there. So we employed this approach and followed up with MRI monitoring 1 day following each sonication, as well as at later time points. And again, we see that there's no increase in the hypointense lesion margins for our mice treated with 0.4 megapascal BBB opening regimen in either the T2 space or susceptibility weighted imaging sequences, indicating that this repeat barrier opening approach should be safe in our model for antibody delivery. So in conclusion, we've demonstrated the first application of focus ultrasound for this disease, cerebral cavernous malformation. We indicate that blood-brain barrier opening can be safe and effective for drug delivery, and that the delivery access to the cavernoma is likely through the perilesional microvasculature rather than the lesion core. We also see that repeat blood-brain barrier opening can be a safe and effective approach for antibody delivery as well. So going forward, we'll begin to explore therapeutic gene and antibody deliveries to the CCM mice. And we're also exploring another modality of focus ultrasound called sonodynamic therapy for the ablation of these mutated endothelial cells. And I would like to thank my lab as well as our key collaborators, which are Wilson Miller, Peter Tverdict, and Khadija Sharifi on this project, as well as our funding sources. Thank you.